Is nutritional screening beneficial for nutritional intervention in the ICU? This is got to do with ICU, not with the wards, but at least the ICU. So this is something that we need to ponder on, because there are so many situations which will lead you to no screening, but at least feed. So this is a question. The practice statement is, nutritional screening for malnutrition in critically ill does not change anything in my practice. So this is the practice question, and let's see what we look into it. I start with this quote: if you cannot measure it, you cannot improve it. This is very true. You don't measure your degree of malnutrition, you don't know how to improve it, or you don't know who they are. It's very true. But then there is this question which comes: improve what? Malnutrition or nutritional intervention, or both? So this is one question that we have to think. So what are we targeting? What is our role of priority that we have to look into? So this is a workflow that each of the dietitian would know, that we are taught from day one to wherever we are, that it follows these sequences. The patient is screened, be it OP, be it in the emergency, then assessed, then diagnosed, care plan, intervention, monitoring, evaluation. These steps go. This is very easy. So only when screening is done, the dietitian is asked for a nutritional care plan, depending on, or an dietitian's review is asked for. That's the general workup. But remember that nutrition screening tools basically develop to identify undernutrition. So what are we missing? Today is the time for overweight and obese categories of patients. How do we screen them? Are they getting missed? Is a question that we need to think. So screening has a role, or feeding has a role. Who comes first, or which comes first? We've been having these landmark papers on malnutrition. It started from the Minnesota study, the starvation study, where they said, you starve a patient and then see what happens to this patient. It's a landmark paper where they talked about malnutrition at that point of time. Following this, then we had the Charles Butterworth study, where he said the skeletals in the hospital closet, where he identified malnutrition in the hospitals and said this is the degree at which we are ignoring our patients, or this is the status of patients who come to us. And then we have what supports nutrition support. So what's important? Identifying malnutrition or starting a nutritional intervention is what the study way back in 1984 that Ronald Coles said, that what supports nutrition support is when we start nutritional intervention. That's more important than. And remember that even today, way back from the skeletals in the hospital closet, malnutrition still continues. Screening has been in progress, but are we able to curtail it, reduce it? No, it still remains the same. So the solution is intervention before screening, and then probably screening. So these are various studies in the ICU that has been done, which talks about the degree of malnutrition that remains prevalent. And what happens when a patient is malnourished? 1 in 3 patients are malnourished. This is a fact that all of us know. So do we require screening to identify this again and again and again? Up to 65% of them are older, and malnutrition increases. This is something that we know, that increases by 4 to 6%, and it increases the cost by 300%. And this is what? Further understanding hospital malnutrition, 24% of them are overweight and obese. So are we identifying them at the right time? Is dependent on disease, when malnutrition is independent of disease, is costly, especially for malnutrition that develops within the hospital when you don't feed your patient correctly. So that is more important. Identify your patient, start feeding, and then see that you correct iatrogenic malnutrition. Diagnosis takes more than a screening tool, because one size doesn't fit all. And what do? We just have one validated tool. All of us almost use the same thing. So it doesn't really apply to every other patient that we have in the hospital. Screening tools do not necessarily indicate who will respond to intervention. This is more important. You're just saying malnutrition is there. But then once you start feeding, does your tool tell you that will it improve or not improve? Doesn't. Okay? So screening tool is not enough. Nutrition screening programs invoke costs for health systems, which is something that we have to know that this is an extra effort. So it's an extra cost to the organization because you're involving personnel for that particular job. And for patients, for example, who have a false negative screening outcome or have a false positive screening outcome because it is individual dependent. The person who is doing the screening should actually know correctly to identify the right person with risk for malnutrition. So it's important to assess the effectiveness of nutrition screening programs. So there's this very good article which was done by a Cochrane review that was done, identified 7,552 studies which talked about screening tools. Okay? Assessing their titles, 3,166 abstracts were reviewed out of this total study of 7,000 odd studies. And what did they find? Did not result in any improvements in the malnutrition detection rate or nutritional intervention rate. So does it really help? The recording of patients' fate only increased. This is the only thing that improved with a screening tool, nothing else. No significant changes were observed in the referral rates to the dietitians because the screening were done. Because the person who's actually doing was not doing correctly, and so there were no referrals for the patient, although we claim up to 60% of malnutrition exists in the hospital. That means 60% referrals should come to the dietitians, which was not coming from these 7,000 odd studies. They found no significant difference in the length of stay. The occurrence of pressure shows malnutrition and treatment costs per patient by doing a screening tool. And this is a very good study by Arabi which identified saying the journey of the patient. What actually supports the patient from admission or the pre-morbid condition to acute illness to the ICU to the recovery phase and to post-recovery. What actually matters is nutrition, not how you are screened. What actually matters is how is the nutritional intervention support provided to you during hospitalization. That's more important. What's the amount of calories, the amount of protein and the macronutrients and other macronutrients that's important in improving the status of the patient and not a screening tool. And there are other variables which actually affect nutritional intervention which we have to be more worried than a screening tool, like the prevalence of insulin resistance, the amount of catabolism that is happening, the expenditure, the energy expenditure, the GI intolerances, the oxidative stress and autophagy. These are things that we have to be concerned and not screening tool. Not receiving nutritional support they needed is the biggest problem. That is what the study that was conducted by the British Dietetic Association said, that we keep patients hungry. So a screening tool is not important. Feed the patient before you actually screen. This is what is a typical feature of an ICU patient. And as an ICU team, it starts with the intensive care team or the intensivist. And what does the intensivist first look into? These. You have this very famous feed, hug, bid. Yeah? Fast hugs bid, okay, which talks about it. The first and the foremost that they're concerned about is feeding, not screening. So this is what is important from the intensive care point of view. So a patient in the ICU has to be fed before a screening can be done. And what happens to this patient in the ICU? These are all the things that actually happen in the ICU. Now, what are the things that an intensivist is concerned about or the multidisciplinary team is concerned about? There is multi-organ disorders. You keep shifting from SIRS to CARS. There is immune response. There's fluid balance that you're concerned about. Electrolyte balance and imbalances, sedation, gas exchange. These are the things that you have to be concerned about. And they all dictate about feeding, and nowhere it talks about screening tools. Nowhere there's somebody who's checking, is the screening done for this patient? This is one study which identified, I know it is not very clear, but what they said is they compared two kinds of patient categories. One category where at admission itself, within 6 hours of admission, they started feeding the patient. And there's another category where you started feeding the patient after 24 to 48 hours. And the outcome said those who were fed first within 6 hours did better than those who were actually fed after 24 to 48 hours. So this is what is important, that you identify. Now that you know this study, what did we all do when it came to nutritional screening for the COVID patients? Did we screen or did we feed? This is important. We fed first. Screening was not really important. So this is important, that feeding becomes very important. I know I am arguing against my norms, but then this is how. And in the pursuit of finding answers for whether we should be doing nutritional screening, there are some studies which I kind of went through. So if you actually look into each of these studies, in the presence of a validated malnutrition screening tool associated with, is it that you are associated with a better nutritional care? The article where I underlined actually said no. And it said that 53 hospitals with 5,255 patients said their screening rate was only 35%. So that means you were feeding only 35% of your patients? No. We were feeding 100%, but screening was done only for. So is screening important? That is something that we have to think. This is another study, nutritional assessment in the elderly. Is it a must? Yes. There are certain lacunas which they found. I know it is not very clear, but they said, at the end of the day, they said that screening, when they did, only increased monitoring of weight at admission. So that's the only thing that they did. Nutritional screening, assessment, the same thing. It said it had poor nutritional screening rates. And so how do we go about identifying patients who are at risk for malnutrition when the screening rate itself is very poor? Then we have this very big study by Bapin Symposium where they said malnutrition and obesity. They questioned the screening tools and said, how do we identify those who are obese with a simple validated screening tool which is actually made to identify undernutrition and not overweight and obesity? We have hospital malnutrition, a 33 hospital screening study which they did. They actually did it in 33 hospitals with 3,000 patients to see what is the number of patients who were screened. There were 60% of the patients were not screened at admission. 60%. So that means these 60% were not fed? No, they were fed. That means screening is not important.
2 more minutes.
Yes. Over, sir. I will argue less. So this is another study. This is another study. Yeah, same thing. But I end my presentation by this very famous quote by Florence Nightingale, who said, every careful observer of the sick will agree to this, that thousands of patients are annually starved in the midst of plenty. We have food, but we are not feeding at the right time, for want of attention to the ways which alone make it possible for them to take food. We have to look for avenues to feed them, not to screen them. Thank you. Remember that every critically ill patient is in your ICU is at risk, so start feeding. Screening is not required. Thank you.
Thank you, madam. Thank you. May I invite Dr. Chandrashekhar now to talk against the motion?
First thing for the chairpersons is that my time has not started yet. So my time had not started yet. And thank you, madam. and most the thing what I wanted to say, I wanted to tell to the audience, already Madam had told you that it's important to feed the intention is to feed the patient, and final intention is a better outcome, less hospital stay, less ventilator day, and no readmissions. That is the intention. Along with that, why we have reached here, many times we have discussed it, many societies have recommended it, so many guidelines have said that the screening is very important. Why we need to screen? Where do you stand first? So before feeding the patient, where was the patient, whether he was severely malnourished or not malnourished, without knowing that what we are feeding, how much we are feeding, then what blame we are going to take from the society or the patient or a medical legal system or ethically, morally. During the patient's hospital stay, whether the patient had gone into a malnutrition in your hands, patient had died because or got infection because of your undernourishment or underfeeding or something like that. All these things now to defend every society had made. Even though there is a fight between each societies, they want their tool to be used for screening. Yes, we admit that certain limitations are there in every screening tool, but medicine is a ever evolving branch. Whatever is available at this stage, if we are not using it, how it will evolve? The point of contention, we need to admit that already Gunadhar had also said that we have a less number of nutritionists, less number of dietitians, less number of trained paramedical staffs. All these are the constraints. We admit that. With all these admissions, well, at least what Madam said that only 35% of the patients were screened, but all were fed, or whether we are going to feed 35% only. These are the discussion sake things. But thing is, these are the limitations. We have to come over the limitations, and intention is to feed them finally. Indicators such as anthropometric measures and total body fat evaluation are not accurate to assess the nutritional status. Yes, that is also an admission. The measurement of a plasma concentrations of a proteins or liver proteins have also a less specificity. Yes, the context, the point for the discussion sake, why this topic had become a discussing point, why the Sanchit had taken this topic for the discussion is that the culprit is here. The European society said that they contradicted on Aspen or SSCM guidelines for the screening, and they said that we don't accept that the nutric scoring or a nutritional risk in a critical ill patient, that is 2002 NRS scoring, we don't accept that. You have to use our guideline. Because of all these contradictions, this discussion point we have reached. But even Aspen themselves agrees and says that the screening is required, but it is by different mean. No validation of a tool, but no validation tool is available, what the Aspen says. But they suggest that other tools like a CT scan, sonography, that is biometric impedance, or the isoso study. Finally, they want screening only by some other means, or they want to improve the screening methods or the methodologies. In general clinical assessment, a general clinical assessment should be performed. In the same paper or the guideline, they said that the general clinical assessment or the screening, what we are assessing, that screening the same time, should be performed to assess the malnutrition in the ICU until the specific tool is validated or evolved. This is what the ESPN is saying. The Aspen is saying that yes, this is whatever is available just now is the better one and easier one, we will use it, the Aspen is saying, and SSCM had agreed upon that. And what they said that SGA available is inexpensive and it can be done quickly and conducted at bedside, and more reliable tool, SGA tool is available, what they said. And the same point, the Indian Society Critical Care Medicine's Vice President is sitting here as a chairperson. I want to impress upon him that it is published in the Indian Journal of Critical Care Medicine that in this publication they themselves agreed upon the Aspen Nutric score and the NRS 2002 assessment tool for the scoring and the assessment of the nutritional status in the ICU patients, critically ill patients. This one more society that is, they said that the assessment is required, and they give a similar or a different tool. They say that must tool should be used. They have a given different steps. Finally, they want to assess that the patient is malnourished or not malnourished. We don't get same patients in ICU. All ICU patients are not equal. We should expect, should we expect that the similar outcome with a blanket nutritional therapy in the ICU? We can't start something like that without starting, without doing a nutritional assessment and without knowing that whether this patient is malnourished or not malnourished or moderately malnourished or severely malnourished. The contention point, yes, finally we have to feed the patient. At the point of hospital admission, 1/3 of the patients are already malnourished and remaining people are going to be malnourished during the hospital stay. And these patients are going to have a bad outcomes. Already, you know that all of you are very well educated people in the nutrition, and most of you are a nutritionist, and some of us are critical care physicians in this. In fact, you people should educate us in assessment and all these things. The same paper, whatever was published in Indian Journal of Critical Care Medicine, their purpose of screening was to identify the patient at risk or whoever is already malnourished. And their next purpose was to start or to initiate the nutrition in these patients. They should have, before that they wanted to have a screening. And final, their purpose of screening was they want to prognosticate, depending on the severity of the malnutrition, they wanted to prognosticate the patient. Even Aspen said it, ESICM had said it, Indian Society had said it, NICE had said it, everyone had said it, every society had said it, every guideline had come out with it. The screening is important. Before feeding the patient, we should have a screening, we should have an assessment. So there is no, nothing like that, no fight between Radha madam and myself that no, we should not start feeding her. No, we should start feeding. Finally, our intention and goals are similar. Regular screening is necessary. In fact, this Brazilian paper says that daily screening is necessary. Daily nutritional screening is necessary to assess the multidisciplinary team should include nutritionists and other clinicians, and probable drug and food interaction should be assessed or monitored, and daily plan change has to be made accordingly, what the even Brazilian study said. Initial monitoring of nutrition, even NICE had said, repeatedly that's happening. The madam had brought one COVID paper. The same COVID paper, similar COVID paper, COVID era paper is also with me. The nutritional screening based on an objective indices at admission predicts the hospital mortality in patients with COVID-19. This is very recent paper. This is 2021 paper. Despite variant screening tools, poor nutritional status was associated with in-hospital death in patients infected with COVID-19. This study highlighted the importance of a nutritional screening at admission and a new insight of a nutritional monitoring or a therapy. That means every patient, at least at the point of admission, and depending on a protocol in your hospital or ICU, regular screening either every 5th day or every weekly or every monthly or at least at the point of discharge, you should screen them whether this patient had gone into a negative nitrogen balance during our hospital stay. Other things that madam had said that straight away we should start a nutritional support, and she said that malnutrition screening is not done in our ICU. The fellow sitting in front, he says that his name is refeeding syndrome, and he says that, wow, I'll come there to your ICU. That's the best place for me. See, there are complications, there are problems. Without screening, if we start a nutrition to the patient, that is, we are losing out on identifying the malnourished patients who are at risk for the refeeding syndromes, and losing out on a rate and intensity of proving a nutrition, ultimately leading to a refeeding syndrome. That means we are creating more and more problem. We are harming the patient. what is the intention of feeding the patient? For the benefit of the patient and a better outcome. But here, by feeding the patient, if we are going to harm them, that's why every society had said that before feeding them, analyze or malnutrition should be either it is mild, moderate, severe grading has to be done. Then you should have an actual plan for a feeding. And even in fact, a nice guideline had given how to start feeding a malnourished or severely malnourished patient, how slowly you have to start to avoid a refeeding syndrome in these patients. Yes, both of us will agree upon certain points that this vulnerable woman had starved to death because she had not been fed. She had not been fed optimally because she had not been monitored or these nutritional assessments have not been done. The next point, why we need a screening or a regular screening is that a medico-legal lawyers are sitting there, especially in advanced countries, something like United States or in West also. They are already put up the board outside, holding outside, the claim hospital malnutrition compensation. Probably this will come to India very soon. That's why be prepared for all these things. A regular nutritional screening is a necessity of the hour, either ethically, morally, legally. In every sense, it is required. Identifying the malnourished patients and including this highly prevalent diagnosis in the medical records and coding them, and from day one, from the point of admission, putting everyday evidence that this patient was malnourished, and systemic or regular screening that is also documented in the file. These all things will avoid the medico-legal problems, and even the insurance reimbursement, all these things, refusals and all would be reduced by documenting and giving the nutrition. Finally, why we want to screen, at least we need to identify who is at risk, what is the severity, when to start, how much to start, how fast we can go and how slow we have to go, and route also. And even it is screening and finding a severity will also give us a prognosis of the patient or a disease process in the ICU. This is my understanding. Even though I am not a dietitian or a nutritionist, this is what is a clinician's understanding in the critical care. This much I need to admit to Dr. Radha.
Thank you very much, both of you. Very interesting to bring the legal aspect in, Chandrashekhar. So I want to just sort of have a views from both of you, and then Dr. Ansari can give us the opinion as well. Is there a real screening tool really available, or we are just having a fantasizing thought process that it will come one day and we will be able to assess patients in critical care units with a real objective way to say that this person requires this kind of assessment or this kind of nutrition?
Yes, sir. There is a screening tool. Yes, there are guidelines, as sir said. There are many guidelines which say that at admission, the screening. So our goal in the hospital is always to improve the level of screening these patients. You know, the only primary goal why you want to do screening is you identify who is malnourished. And so you focus your intervention first on them before you focus on everybody else. That's the main reason. So there are validated screening tools which you can identify, but the only lacuna, as I pointed out, is it presently does not identify overweight and obese patients, but then yes, the undernourished are identified so that you focus on them.
Yes, I think undernourished is fairly reasonable. You identify them and you give more attention to them. What about energy expenditure? Do we look at objectively energy expenditure? and then we decide whether, so this category of patients who are undernourished, I'm not even talking about them. I'm talking about patients in a screening tool comes out to be reasonably nourished and has a high energy expenditure. What do we do about them?
See, when we discuss about energy expenditure in that, at that point of time during that day or during that stay, there are different modes and tools available to calculate this energy expenditure. Sanchit is using a different tool, and basic tools are also there. But by looking into energy expenditure itself or using energy expenditure itself, we cannot go on feeding the patient. We need to know that a background status of the patient, whether this patient is really severely malnourished patient, how aggressive we have to be, and how not aggressive we have to be in feeding patient, so that we can avoid other complication related to feeding or not feeding.
I would ask Dr. Chandrashekhar, one important thing you emphasized, daily screening. Do you think it is feasible, practical, and how much impact will it kind of really have, rather than a weekly screening, or probably again screening the screened ones on a targeted manner?
Correct. Do these all things, yes, the constraints are there, manpower is less. In the same way, more frequent screening are good. At least we should have a once a week screening, at least. But that is something royalty or something you are a rich man want to spend. Some countries have higher resources. They want to screen them daily. That is a Brazilian paper. They recommended that the daily screening, even the food and drug interaction they want to see. And some patients, specifically some patients are on anticoagulant. You need to at least keep a watch on that, what this patient is getting, which meal he is getting, what feed he is getting, what oral anticoagulants are going on. That's not this case only. In something like these patients, they need attention.
Madam?
Yeah, when you say screening, okay, it's the start of the entire thing. But when you say progress, when you go ahead, and we actually say ahead. When you say ahead, it's there. When you say ahead, then, you know, the problem is we don't have, like what it said, there is no real validated tool in critical care. I mean, it is time, see, the Europeans got together and made this ICALIC device. The experts, I think we should get together and make a kind of a screening tool which will be applicable to our countries, is what it says. Like even things like the bioelectrical impedance analysis, all this in critical care, I don't think, and really speaking, nutrition doesn't work in 2 days. Nutrition is going to take weeks.
In fact, this is the reason why I asked that question. One of the very impressive study which was done in COVID-19 actually showed that the resting energy expenditure in the first week is around 95% of what Harris-Benedict equation predicts, but goes to 124 next week, 145% in the third week. So which means, contrary to what we all feel, in the first week, and which will be probably one of the topic of the next debate, whether in the first week it really makes a difference about going on specialized nutrition or trying to start it very early in a very organized manner. But certainly as the time spent in the ICU is more, PICC, prolonged intensive care, catabolism is going on, I think nutritional screening becomes more and more important there, rather than being, as Madam said, feed first and probably screen later. At the same time, screen first for a very malnutrition, sick individual who is on a ventilator for long, and then tailor the feeding accordingly.
So I'm going to talk about what you sort of talked about first week, whether you need to give feeding or not. I think that's the debate coming up whenever Sanjit gives the green light to do that. But I was just on a lighter note talking to Ansari, my friend, and I said, feeding in ICU and nourishment in ICU itself requires a nourishment to the person who actually wants to give it. Because it's such a big topic and there is hardly anything you can actually rely on in a reliable way. How do we screen it? When do we start it? Whether first week is good, whether immediately is good, or we wait for 7 days. There has been a plethora of studies each contradicting each other. So really the data in ICU is very, very smudged. You have to be a believer in one and keep on doing what you think is right, and wait for an accurate way to actually predict that which are the patients who really require to be fed in a very aggressive mode.
Right. So the end of the talk would be probably we need to screen, and probably it's a great tool when we have to actually diagnose undernutrition for certain.
Feed for screening.
Yeah, don't hold the feed for effective screening. Like someone comes and says, let me do this particular device. Wait, don't feed. No, it should be feed. And
Meticulous
yeah,
screening doesn't make you smarter. Let me be very
Yeah,
honest.
yeah.
It just tells you that, I need to change my feeding policy or some kind of disease-specific nutrition. But at the same time, mindless feeding, knowing, being in a trap that I am just feeding my patient the standard calories while the patient has CRRT, ECMO and other problems, you are completely going tangent.
tangent. Yeah. So thank you very much, Dr. Radha, for coming all the way from Hyderabad.